Well, good morning, everybody, and welcome to another Canadian Nuclear Isotope Council webinar. My name is Evan Cameron, and I'm the Manager of Public Affairs and Communications here at the CNIC. Today's webinar is a unique one, as the CNIC is co-hosting today's discussion with two other advocacy groups within our sector, the Canadian Association of Nuclear Medicine and the Canadian Association of Medical Radiation Technologists. Before we dive into the discussion today, I wanted to take a moment to extend my sincere thanks on behalf of the CNIC to both CanAm and CamRT for the partnership on today's webinar and for the critical work that they lead. We look forward to more opportunities to work together in the future. This morning, we're joined by leaders from those two organizations, in addition to some academic and industry leaders, for an important discussion on one of the most critical issues for our sector currently, the shortage of nuclear medicine technologists. Before I introduce you to our distinguished lineup of speakers, I want to briefly remind you all that there's a Q&A button at the top of your screens. Throughout the discussion today, you can submit your questions there, and our moderator will address them to the panel towards the end of the discussion, if time allows. With that, let me introduce you to our speakers for today's discussion, starting with our moderator. Kimberly Haynes is the Healthcare Systems Associate Director for Radioligand Therapy at Novartis Canada. In her role, Kimberly identifies systemic barriers to support the strategy of innovative, targeted radioligand therapies in the field of nuclear medicine to help Canadian patients with advanced cancer. Alexander Fontana is the Head of Strategic Operations, Engagement and Advocacy at the Canadian Association of Nuclear Medicine, where he leads national initiatives to advance nuclear medicine practice, workforce development, and patient access to care across Canada. He is also the author of CanAm's National White Paper on the Nuclear Medicine Technologist Workforce Shortage. Chris Topham is the Director of Advocacy and Communications with the Canadian Association of Medical Radiation Technologists. With a background in immunology and medical writing, Chris joined CamRT in 2010 to build their best practice guidelines and moved into the director role in 2015. Laura Thomas is the Associate Dean of Medical Imaging and the Academic Director of the Center for Integrated and Advanced Medical Imaging at Mohawk College. With extensive experience in imaging education, she advances clinical excellence, academic innovation, and workforce development. And last but certainly not least, we have Catherine Latani, who serves as the Academic Chair for the Radiological Technology, Nuclear Medicine and Molecular Imaging Technology, and Radiation Therapy programs at the Michener Institute of Education at University Health Network. In this role, she leads academic program development and quality, ensuring strong alignment with accreditation and professional practice standards. Now, with that, you've met our speakers. I am very happy to pass the floor over to Chris Topham from the Canadian Association of Medical Radiation Technologists to kick off this morning's discussion. Over to you, Chris.
Thank you. It's just my computer's taking a moment here. It's going to present. Thanks, everyone. It's can't see you, but it's nice to know that all of you are here to listen to this. Can you see the slides, Evan? You're good? Okay.
Yes, we can see them clearly.
So I'll be quick because we want to get to the discussion. So CMRT's excited to be here. This is part of a very important discussion we've been having for a number of years about the growing shortage in among MRTs and specifically among nuclear medicine technologists. CMRT has about 11,000 members across the country, many of whom are nuclear medicine technologists. And one of the things we do in our association work is sort of try to track workforce on a number of parameters. And I wanted to show you those today just to set the stage for what we're going to talk about later. So to begin with, these are the numbers that we get from regulatory colleges. So these are the numbers that really represent those nuclear medicine technologists that are registered across the country. We don't know from these numbers where they work, but what this does is it shows how the profession has grown or not grown in this case over a number of years. I apologize that we don't have the 2025 numbers, but what we do know is the certification as the certifying body. We do know that there wasn't a bumper crop of nuclear medicine technologists. We would expect that number to be in the vicinity of 1,840, 1,850 this year as well. So those are the numbers that we see across the country, and those are important to remember as we go through things. What we also do is we survey people throughout the years in order to track how the workforce is doing and the health of the workforce. Biannually, we run a survey of the workforce with managers across all parts of medical radiation technology. And what I'm showing you here is just medical imaging, not including radiation therapy. And you can see that really, since we began doing this survey, a crisis has really grown across the entire profession. On the right, you can see nuclear medicine, which in 2018-19, prior to COVID, would have been in a relatively healthy state. And that we can see there a growing shortage as reported by managers, to the point where the last time we did this survey, which was last May, the average report was that there's a 15% vacancy across departments. I'll show you more specifically nuclear medicine so you can see the numbers and how they've grown. So, at a point of 2%, very healthy, in fact, probably a point where there aren't many jobs for people looking for them, to the point where it's really a crisis now. I did just want to point out it's an ecosystem, is medical imaging, and it's probably relevant to the rest of the discussion to know that the reason we think CT and MRI didn't climb like the other two is due to certain interventions that took place at government levels in order to address those two modalities. So importantly, MRTs can cross from one discipline into another, and certainly we think that happened. We haven't been able to quantify how many nuclear medicine technologists would have crossed into CT, for example. Into MRI, they would have needed to do an extra entire educational program, but for CT, in many cases, it's not too burdensome for them to cross. So in addition to checking that, I think we all agree that 15% is a very unhealthy level of vacancy across a profession, and we're calling it a crisis, certainly. In addition to that, what we're seeing is MRTs are burnt out. Every couple of years, we also run a mental health survey of all our members, and we get a very good response. And these numbers are not asking if people are burnt out. We use the Maslow burnout index, which is a clinically proven burnout index that's used across the scientific community. And this gives us a reliable look into what the state of the MRT burnout situation is. And as you can see there, I think I'm having trouble seeing the numbers myself, but there was a massive jump following the COVID-19 years, where MRTs as a whole became a lot more emotionally exhausted. We repeated this survey last year as well, but I don't have the numbers to share with you. They're still being analyzed, but I can confirm with you that these numbers have not improved from what I've seen. And we're hopefully going to get nuclear medicine specific numbers from some different work we're doing with the Royal College, but those are yet to come as well, unfortunately. Maybe a future webinar for that. So moving on, we thought it would be useful to do some sort of very back of the napkin math for you here to show you what we think is required across the community in terms of workforce. And so just how does a 15% or 15% vacancy translate into totals? So what we feel we need, if we were to go to zero vacancy, would be 2,175. So below then, just some even cruder math to show the number of technologists in absolute terms that we would need to get to a 0% vacancy, 5% vacancy, and 10%. And the reason I highlight 5% is because I think we'd all admit, those of us that work with larger departments, a 0% vacancy is not something that it ever really happens, and it's not even a healthy state to be in. Whereas 5% is within the realm of healthy. We showed before 2% was what was being maintained as sort of a healthy level. But in terms of what could be attainable and what we should be aiming for, we think that's a number that we should be looking at. I just wanted to then quickly go on before I pass to Alex. That's the state of the workforce as it is. So vast shortages, and the people that are left behind are very exhausted. And what that means is they're verging on, they certainly have thoughts about leaving the workforce themselves. And if we continue to, have inaction in this field, the risk is that more and more people will leave, and we won't be, we'll have an even higher number than 225 as a target. But what's happening on the inputs to the system? So these numbers aren't perfect. These are survey numbers as well. So I apologize to my educator colleagues, and we can talk about these more on the panel. But these do offer a bit of a trend to show how many people are coming through the system and how many people we should expect to come through the system. And once again, apologies, there's a survey that's going to be in the field that would look to 2028, but we don't yet have that. But so what you see here is really a bit of a stagnation. You saw it in the numbers of technologists, you see it in the number being educated, where the response nationwide to this growing shortage in nuclear medicine technologists hasn't occurred. We haven't really yet increased the number of seats, at least in the data I have here. Now, I've heard things from people across the educational sphere that indicate that this is happening. So hopefully our next survey will show that. But what we also have at CMRT is we're the national certifying body. So we do have numbers that are not survey based. These are actual numbers of people attempting. And what you can see here, attempting our exam, and what you can see here is really no growth whatsoever since 2017. And we know that in the context of the aging population that we're in, this elderly population, once you cross the barrier between 70 to 80 years old, your demands on the imaging, on medical imaging wholesale, grow immensely, and nuclear medicine's included in that. So, we're not expecting to see large bumps in this yet, and that's why we're hoping to have some action. And so this last slide is just what we hope to achieve going forward as a group of like-minded individuals seeking to, solve this problem that we have in front of us. If we think that the projected demand is that gray line, the red line is continuing to do what we're doing now without any action. We should expect to see flatlining and a gulf between the projected demand and what we're able to do. And all those lines in between represent different approaches we could take. The yellow one is just matching. If all we did was match the curve, and then as you can see in between, I would say we need to go somewhere in the vicinity of the green to get to a better place in that 5%, but we can discuss that more in the panel. So that's it for me, Evan. Thank you.
Thanks so much, Chris. That was a very, very informative presentation. I think a great way to kind of kick off this morning's discussion. So thank you. With that, I will pass it over to our friend Alex from the Canadian Association of Nuclear Medicine to dive a little bit deeper into that white paper that I mentioned earlier. Alex, the floor is yours.
All right, thank you, Evan. Thank you, Chris, for the numbers. For dear attendees, some of the numbers you will see on my slide are a repetition of what Christopher already spoke about, and this is actually really important to keep in mind. So a couple of key numbers that I wanted to highlight regarding the situation, and especially within the white paper. The NMT workforce is really small. 1,800 people for Canada is extremely small, and that's a big problem because the country is big and the teams are small. If you look at it, 20 to 33%, capacity loss happens when even one technologist actually is absent to service. And that's a big problem because as soon as you remove those capacity, what happens is that infinite, the patient suffers and the patient is actually not able to receive the treatment. So that's a big problem. We're going to be seeing after into the education and recommendation that the education section of this presentation is important. Why? Because as we know right now, there's only 5 accredited program across Canada, and it's only representing 50 to 70 graduates per year. But the problem is that more than 20% of those 1,800 people we know are age 50 and plus, and their risk at leaving. And the graduates are not able to even the numbers of technologists. So that's a big problem. And we will see in another slide that, as we know, money is king, money rules, and that's a big element of the problem. So to put into light what's really happening across Canada, we worked on a split to show the repartition of all the technologists across the provinces. And it's important to keep in mind that even though Ontario and Quebec represent the biggest groups of technologists across Canada, there is disparities within those provinces. Why? Because the access at the north, for example, of Quebec is way more difficult to get compared to the big hub, such as like Montreal or Quebec. But it's the same thing for Ontario. If you go to the north of Ontario, the access to the services and are extremely difficult compared to the hubs in the big cities. So that's important to keep in mind. But as you can see, the repartition is really poor, as we can see that there is some provinces, especially in the eastern side, and I want to thank all the people that are working in those provinces, because I know they're struggling. It's extremely difficult for them. So as we can see, the repartition is a problem. Why? Because the cases are increasing, but the demand is so high compared to what the services are able to provide, so that like it's putting them into a burden, a stress situation where they're like overworked, burned out, and they're like struggling. If we looked at those key factors, we know that, like, as I mentioned, we have like 5 accredited programs, but like there is 20% of the workforce that is, imminent to retirement. And as Christopher mentioned, there is vacancy increasing, but we know that like the unemployment within the profession is only 1.5%. So it's extremely complex to understand that like all those factors puts the NMT workforce into a cycle that will not get better. In fact, it's going to get even worse in the future if nothing is done. So it's important to keep that in mind to avoid going into a crisis situation. Now we're talking about the big problem. As you can see on the screen, and as I mentioned before, wage disparities is a key factor. Why? Because as you can see across provinces in the station, the average salary per hour is extremely scarce. As we can see, Manitoba, and it's the highest paid after step 3, so step 3 is like third year, is at $53 an hour. But as I mentioned, the provinces of the East, and especially New Brunswick, and this is actually really sad to see, are only paid $29 an hour. So that's an 83% wage gap. This is completely unacceptable, especially when the national mean is $40, being paid $29 is completely unacceptable. So I want you guys to keep in mind that money is king, money rules, and this will actually impact how people react, how people behave, how people select the provinces, how people select their education center. So that's really important to keep in mind. I've had a slide. So across the white paper, and during the time I was writing the white paper, I spoke with a lot of technologists. I received a lot of message from those technologists. I received testimony, and you have a small taste of what I've received. And I've received 1,000 answers to questions. And I wanted to, represent that. I want to tell them that, like, we heard you. I tried to put you there into that white paper so that, like, you feel represented. And I'm going to give you a good like 20 seconds to read all those testimonies, because I think that this is really important to understand that like what is happening on the ground is the reality, and like the I heard or I think are not, acceptable reflection anymore. I'm going to move on. I hope everyone had the time to read that, and I know that the slide will be available, but just wanted to give you a sensation of what's happening. When we talked about what's happening, and at the CNN we work for like patient access a lot, and we looked at what's happening within the workforce. Like it's a domino effect. It was mentioned, 50.3% vacancy rate is a thing, but there is a lot of backlogs. The wait time is terrible. I've received feedbacks from a lot of institutions and people that told me that, like, yeah, some of the patients, needs to wait 6 months, some of them needs to wait 10 months, some of them needs to wait a year, some of them needs to wait more because the equipment is not working, the people are not there to work. And because of all those problems at the start, then it impact the clinical pathway. So that, like, there is delay into the cancer staging, for treatments. There is postpone, procedures. There is, like, surgical studies that like stalled. So all those problems actually leads to a final, problem. And as I mentioned before, money is king, where like the system cost, is extremely high. Like all the emergency departments, are being overworked. There is an heavy reliance, as I said, on overtime. And if you overtime your people, they're just going to be quitting. They're just going to go on leave. They're just going to stop working because they're like at the limit. And this leads to also a problematic where if you don't have the staff, this is great to have multi-million-dollar equipment, perfectly brand new into a room, or if not even working. But if you don't have anyone to work them, then that's a waste of money, that's a waste of time, and in the end, the patients suffer, and that's not acceptable. If we move on then, and that's one of the recommendations, I'm going to go through the 4 recommendations of the white paper. The first recommendation that we wanted to go to is an expansion of training. Okay, so that's extremely important that throughout, those 5 accredited program, we know at the moment it's like 50 to 70, and as Chris mentioned, it's going, but it's not enough. We need to expand. Why? Because with structural expansion, we will potentially be able to treat more by graduating more people. But in fine, what's important to understand is like we need the people that get graduated to go not just to the hub, but to go to the smaller institutions across the provinces. And we're going to see into a panel that thanks to Laura Thomas from Mohawk, there is another program that is actually being built at the moment that will potentially, helps kind of solve this first recommendation. The second recommendation is extremely important because when we looked at what's happening within the nuclear medicine ecosystem, there is a real struggle to get access to data. And that's the reality. Everybody's working in silos. Everybody, any association, any entity, any individual works for its own benefits. It does not share the numbers, and that's not acceptable. We are a nation. It's important that like an organization, which will be the NCNMC, the National Coalition for Nuclear Medicine Council, will represent as the national governance body to develop and oversee a coordinated national intelligence platform. This will lead to getting the data from all the actors within the system to be provided, to be gathered, to be treated, to be put into specific algorithm to treat, and then to be provided to the population. Why? Because, and I'm taking an example, I'm not giving names, but a province X have X amount of data on what's happening on the floor, how many, procedures they do with the PET, the SPECT, and, the wait time, but they're not sharing it. So that like how a patient that is living near or how a patient within the province can have access to this information, it does not. And that's not acceptable. There is a way where things need to be gathered together, where everybody is acting as a unified group, because together you're stronger. By yourself, you're just going to be doing small things. So the NCNMC is the second recommendation, a joint force, a national intelligence platform. Moving on, when we looked at, the current staffing approach, and that was like, really about like national standards for safe and, sustainable staffing, it is extremely important to understand that procedures are moving, protocols are moving, technology are evolving. What we know right now, what we're learning right now, might be outdated within a year or 2 years, especially with the technology advancement. And with this problematic comes to the fact that because we're not graduating enough technologists, then the current workforce is forced to overwork themselves, retrain themselves on those new technology, new procedures, new process. So it is important that, with governmental support, the CNM, its partner, needs to develop an evidence-based benchmark so that like it's possible to define a minimum numbers, and I'm quoting minimum as this is a short-term solution so that like we are able to forecast potentially what's going to happen in the future so that like when we are facing the problem, we already have contingency plans. So it's extremely important to keep that in mind that like it's evolving fast, and if we want to keep up or if we want to go further, we will have to put national standards. But it's not standards from one association, it's standards from all of us. And last but not least, as I mentioned in the recommendation 3, all those innovations are important, but all those innovations, needs to be coordinated, It's not just, oh, I saw this initiative, oh, I think that this is great. No, we need to act together. And this actually echoes what's happening in the recommendation too, when I was mentioning that we need to have the NCNMC, the National Coalition. Why? Because this will act as a national platform for collaboration, guidance, and action. So as you can see on this radar, there's like 3 steps, which is going to be like horizon scanning, clinical integration testing, and then active evaluation. Throughout those process, we will be able to have some access to the data, the information, and then we will be able to assess, provide, and prevent. And those 3 key factors are important to keep in mind. Why? Because with RLT coming, with theranostic coming, what's currently happening within the nuclear medicine, environment is, let's say, it's version 1.0. With what's coming, we're going to go into 3.0. And I'm going to conclude with the fact that I gave you those 4 recommendations, but once again, as I mentioned, silo is not acceptable anymore. Those 4 recommendations need to be put together. They must operate as a coordinated system, because without those alignments, the workforce disparities will just keep going. Okay, people within those provinces that do not have access to or that are struggling will keep struggling, and in fine, who will suffer the most will be the workforce and the patient, and that's not possible. Thank you.
Thank you so much, Alex. In the interest of time, I think we should move right into the panel discussion because I know we have a lot to discuss. So to do so, I will pass the floor over to Kimberly from Novartis, who will be moderating the panel.
Thank you so much, Evan. Thank you, Alex and Chris. I think you outlined very clearly what a complicated issue this is that we're speaking about today. We see it in all areas of healthcare, but when we look at the emerging market right now, and what we anticipate happening over the next 20 to 30 years, this is a critical issue that needs to be addressed now. So I'd like to kick us off a little bit in that complication just by asking, how can we address in Canada specifically the persistent shortage and uneven provincial distribution that we see in nuclear medicine technicians so that we can ensure that equitable access to nuclear medicine services for patients nationwide? That's a broad question. Feel free to tackle it as you need to. But I'd like to invite Catherine maybe to kick us off for some comments on that.
Thank you very much. So, so just some context, Michener has been delivering education services for nuclear medicine technology for many, many, many years. So we have actually, when the pandemic hit, we actually had increased intake in 2022. We were prior to the pandemic, it was below 20. We are now above 20. It's unfortunate that when we see it from a national scale, we're not seeing that impact across the board. I think that working with, I agree with the comments about we can't be silo anymore. We need to work together. We need to be able to work with our clinical partners, with the governments of those underserved areas, and establish how do we help to recruit locally, to encourage more people to consider the profession, to promote the profession. The profession is unknown outside of healthcare, even within medical radiation technology, to actually promote awareness within the public to that point, so that we can encourage people to actually consider coming into this profession. And we're working on strategies to recruit locally so that people can then train locally and then stay and be hired and work locally. I'll hand that over to, I want to hand it over to Laura because I can see her nodding.
Thanks, Catherine, and thanks, Alexandra and Christopher, for your synopsis there. It's an interesting thing because Mohawk is net new in the space of nuclear medicine education, but we have been delivering imaging education since the early 70s. We've been involved in all other fields of imaging education at different levels: degree, advanced diploma, graduate certificates. And so we made a big push about 2 years ago to really do an evaluation of what is needed. And it really just translates to everything that's being said here. There are a lot of people out there who are starting to understand this field. There's a lot of news about theranostics. There's a lot of news about nuclear, across the board. And so young people and people who are in established careers are looking into these options. But the system that we have built for education isn't designed for most people. It's designed for teenagers and people in their early 20s who are looking to find their first career. So Mohawk has decided to try and do a few things differently, try and deliver our programs in an online capacity with on-campus skills intensives, engaging learners where they're at so that we can try and place them where they live, instead of asking them to move down here and go to school for 3 years and then go back home. That's our intention, but it doesn't come without some obstacles and some hills to climb when it comes to ministry binding policy and just the framework of colleges in general. So I'll stop there. I'm open to questions. I think that we have a lot to learn as we're making our way through this space, but we're working with colleagues at CAMRT and at Michener, we have opportunities to really grow and develop. So.
Alex, over to you.
Yeah, I don't want to play, like the devil's advocate, but when we talked about an even provincial distribution, and as I mentioned in my presentation, wage is a key factor, but it's also, the province in itself. And I'm once again taking an example in the East because I know the struggle, but the program is they're referring to the LLC, but the fact is a student that gets to the LLC get a debt, because he paid for his education. And the fact that, okay, if he's within the province, he might be loyal to the province because, it's his roots and his family. But a student that comes from another province and studied the LAUSI, when he's going to be asked if he want to stay within the province, and I know a couple of students that are like finishing their clinical, trials that I got proposed a position within those provinces will not stay. And as I mentioned it before, like getting paid a decent amount is one of the key factors for the workforce. You're young, and I understand that like when you're like outside, leaving the program, you graduated, what you need to keep in mind is that like you want to think for the future. And if you make your calculation and you decide that, okay, I'm $10,000 in debt, and then I need to get paid X amount to be able to live comfortably. And I know that like potentially the job I'm going to do is going to be extremely difficult for me. I'm going to be overworked. I'm going to be stressed. I'm going to be close to burnout. Then you take all those factors into consideration for your future life equation, and you're like, okay, I got my degree. I'm able to work in any provinces I want. Why would I stay into a province that doesn't pay me enough, where I can go to another province and I'm young, I can move, I'm going to get like 40, 45, and even sometimes like almost double what, is offered to me in the province I graduated to. So that's also one of the factors that I think is important to keep in mind when we're talking about an even provincial distribution, because pointing out provinces like, okay, we're struggling there, okay, we have a problem there, is a fact. But we need to think about what's behind this reflection too, and take into consideration that at the end of the day, we're all human. We all want to live with like a decent, amount of money to be able to do what we want. And if I work to live, then, there's a problem.
Thank you so much. Can we move over to Chris maybe to comment further?
Yeah, well, thank you, everyone. I mean, we can see it's a complex problem. We started by saying it was a complex problem. And, we mentioned provinces a number of times. And I think as a national association, we have come to appreciate that. This is my first time going through a shortage as a director of advocacy, and it's certainly probably everyone's first time going through like a massive pandemic fueled shortage. So I think what we're seeing is a system that relies on 10 different governments and 10 different systems to provide, and especially a system like nuclear medicine where there aren't even schools in some of those places, is extremely complex. And so I really appreciated, all those recommendations. None of them should be done alone. The recommendation is that we do all those recommendations and that we should do them as a collaborative. I think that's so important. And I'm a data head. I know that when I go to speak to a government, my job is so much easier when I have data. When I'm speaking to a government to expand seats, and we can talk about whether they did or didn't. If I had those projections in my hand, if we had the data gathered and had them in my hand 5 years ago when I had those discussions, I think we would be in a different place. So I would say some of the things that we should have been doing all along, we should start to do. And that includes, coming together as a community and doing these projections and sharing information and, a consensus projection. And then doing the things like the seats, which are, to match the projection, to go on the curve that I was showing at the end, and lots of other good things as well. I mean, I love what Laura's saying. It's been so apparent to me, helping people outside of the teenager population see this as a career. There are many people who are disillusioned with other professions who simply could never do this because of that barrier that they face. So I think that's a really good initiative to expand sort of the audience for this kind of profession, because it is an exciting profession. And particularly with the advances coming down the line in the next few years, it's very exciting. So I think there's a lot of potential, but it's going to take a lot of collaboration and concerted effort.
Agreed. Thank you, Chris. I think we're going to pivot slightly and dive in a little deeper here. So when we look at the complexity we're speaking about, the opportunity for the technologists to build a better platform, what strategies are going to be most effective when we're increasing that capacity and trying to look at that, trying to look at recruitment, especially when we're looking at smaller provinces or rural areas, when we have that real fragility of abilities to keep people in those locations. And we see that being an area of, we're seeing it in the comments already, that's an area of concern. We saw the wage disparity. And so could I hand that over to Laura to comment?
Yeah, I think that the conversation has to be different. So most colleges and universities have a full-on marketing initiative that is geared toward the younger students. And I think that the connections start here. They start at more of a grassroots level for us, and connecting with these groups as well as with the ministries of health across the smaller provinces, so that they're the ones who are front line hearing that there are issues. They're the ones who hold on to the purse strings. They're the ones who can figure out funding to support some of these gaps. And I think if we started working with the ministries of health across the country, we could start to help where these niche professions need to be grown and with some opportunity. The hard part is that when we're in different silos. Ministry of Health, Ministry of Colleges and Universities. Colleges and Universities says, well, if we're short of these technologists, let's throw some money at that, and we'll, increase the number of students going into the program. But the money itself isn't the only thing that needs to happen. They need to be targeted, because we can't be graduating, 40 students from Hamilton. They won't get work. But if we are strategic in how we recruit our students and plan forward and work with groups like this, we can make a difference. And this type of education can be taught in a different way. So I'll hand it over to Catherine.
We're tag teaming. Just to pick up on what Laura is saying, I totally agree. It is about, because it doesn't, at the end of the day, we could be taking in a whole bunch of students, but when they graduate, it's where do they go afterwards? So all those other factors that both Alex and Chris have highlighted in terms of wage, that attractiveness, et cetera, that all comes into play. So when it comes from a recruitment perspective, it is really about, working with everybody, as clinical partners, reaching out and working on strategies that enable folks to recruit from their regions, so that hopefully, and then allow them to be able to train in their regions and have some sort of incentive for them to stay. Because they know their regions, right? The other piece is, there's another component there about being able to also encourage folks who perhaps are looking for a change in where they are right now. So there is an initiative, for example, that Michener has been funded by the Ministry of Health to promote, which is our Northern and Rural Practice Program, right? And it's really about focusing on enabling folks to learn more about what does practice look like in these different communities, that it is different than living in a big city and working in a big city, but also, so not just getting some education about that, but also giving them the opportunity to be able to actually go and do a fully funded site visit, right? For example. But this is an example of how we could be working together with agencies to try to promote and support across the board. And I will just put a plug out there. There are modules there specifically for diagnostic imaging and nuclear medicine as well. So our professions are being recognized as a need.
Thank you so much, Catherine. Alex, if I hand it over to you, I wonder if you could also fill in a little bit, some questions coming in, such as, are the disparities, do the disparities exist between like MR, CT, other areas as well? And if so, is there a strategy that we should be putting in place to try to work with the government and the ministry as a whole?
Well, that was exactly where I actually raised my hand, because I've been looking at, the conversation, the comments, and the reality of also, the question. And I'm looking at it like, we talked about we need to increase capacity in recruitment. Okay, fact. But when we go to the school, when we go to high school students, we need to have the right, speech. We need to have the right presentation. We need to have the right arguments. But that's one of the point. We need to recognize that NMTs, are a profession that needs to be recognized as equal as other specialties, because it's not possible for a student, if he's looking at what I'm going to do in my life, and I'm looking at, and it's like, oh, MRI, oh, ultrasound, oh, CT, oh, they're getting paid, and I'm giving numbers, but I've seen them throw the charts from $5 to $10 to $12 more into another specialty than NMT. Okay, what are you going to offer me? What's your call for me to join your specialty? How can I go into a specialty that is not recognized at the worth from the education point, from the ministry point, from the province point, where like you're young and you want to make money, and I'm sorry, I'm quoting money, where I know that like if I go to another, I'm like, okay, I'm gonna go to ultrasound, I'm getting like $10 more an hour than like NMT, and I'm not putting my life at risk because it's different procedures. What's the talk? How do we work on this? Do we go to the provincial level and tell, okay, we need to have a education program to go to those schools to speak about what's happening? If prior to that, you don't even recognize the NMT specialty as an equal, So that's one of the points that leads to, I'm a student, I'm looking at a specialty, it's not recognized as the same as the other specialties. Okay, I might not consider it. And then I'm like, oh, I'm looking at the value, not getting paid as much as them, more work. okay, more danger, more difficulties, why would I consider it? So once again, I'm putting my devil's hat on, but you know, I'm putting myself into the boots of a young guy, and I'm like, okay, if it's not recognized as an equal, there, why would I go there? And then, oh, it's not paid. Why would I go there? And so you have all those arguments, and then there is a need for a joint communication per provinces federally to put forward NMT specialty on the light. As of right now, it's a small profession. It's under shade of like the bigger ones, and the problem is like if a plant doesn't see sun, it's not going to grow, and that's
Yeah.
basically what's happening with NMT right now.
Thank you very much, Alex. That's a really good point, and I can see that Chris would love to chime in on his thoughts there.
Yeah, well, I totally agree that, each profession, and particularly with regard to the webinar today, nuclear medicine deserves to be fully respected for all the amazing value they bring to patients. I think the work we proposed that we would do on, looking into the workforce and the units, and I think that will bring to light a lot of interesting things. I think also, I think as I said before, I truly believe like this opening it up to people beyond, young adults and teenagers will open up a world of possibilities. I also know that this world of wage disparity and these large gaps has come about. It's been exacerbated lately, and it's because this is the equilibrium we're now living in. When a province decides, hey, we're short, we're going to bump these people's salaries, we're going to offer them, undisclosed signing bonuses, we get into an arms race. So I would just bring us back to say, I think it's imperative that we do project realistically what this profession is going to need, including in a world where theranostics has to be delivered by this profession. And, those projections be used in a real way to open discussions with governments and educational institutions and all the relevant ministries to make sure that we're tracking on the right track. Because, when there's a 2% vacancy, the governments aren't going to be, they won't be looking to sort of compete with each other. And I don't think even the ones that have won this race loved this period of time. I think it's been a very difficult period for everyone competing with their fellow Canadians. So yeah, I think a lot of collaboration and effort. There's a lot of players in this, but I'm happy that some of them here are in the room listening to us and certainly on our panel. So
Yeah.
I'm
Thank you,
hopeful.
Chris. Yes. We just had a comment made about some of the international pieces that are there. So I think as we look at the policy changes and innovations that we need to ensure that expansion, to ensure that we're trying to build that workforce right now for technologists, I'm wondering, Alex, maybe you'd like to kick us off and comment. I don't know if you would like to dive a little bit into some of the things we're seeing globally as well, or whether you'd like to stick with just Canada. It's a big topic.
Well, I do like this question. Unfortunately, if we want to talk about this specific topic, it would take hours and hours because when I was looking at, the numbers just in Canada, it was difficult, especially for international. And I also looked at what's happening into other countries. Okay, I looked at what's happening in Europe, especially like Germany, France, UK, and I also looked at what's happening, in Australia, New Zealand, and they all face the same problem. Okay, they all struggle and they are still struggling, which is surprising to a certain extent because some of them, tackled the problem earlier.
Mhm.
What I'm seeing as, the problem of integrating international students, or international certified people in Canada, and I'm looking at it in a way that like depending the provinces, entry to the country, entry to the profession, entry to the workforce are complex, but I think that regulators might be more open, to discuss that. I think that Christopher actually might, be more aware of what's happening because for me, when I was doing the white paper, when I was focusing on Canada and I looked at the others, I was like, even other, countries are calling for those internationals, but it's not even enough. So,
Chris.
if one country is struggling and another one is struggling, then you're just like taking the problem outside of it. And I know that like, we're in Canada, so for me what matters is Canada. But that's the reality of it too. You just move the problem to another country.
This is an urgent problem that we're having in Canada right now, but it is a global phenomenon that we're seeing repeated, and nobody has solved it yet. Maybe Canada will be a leader here. Chris, what are your thoughts?
Yeah, my thoughts are I echo that. We know for a fact that every country we've spoken to over the last 5 years has some sort of shortage. I mean, when we actually compare side by side, it in some cases ours is actually worse. Um, but what I can tell you is CMRT applied for funding from the government 3 years ago, and we're successful in getting a funding agreement with part of the federal government to look into this problem. And we are addressing certain things like the sort of the credential recognition process, but also how people would integrate after, credential recognition is often the problem we hear about in the news, like people's credentials aren't recognized. It's actually not the biggest problem in our profession. The problem is them international people integrating into the workforce long term, whether they don't succeed on the certification exam for whatever reason, or they don't end up integrating properly. So we are looking at strategies to help with that, and we're starting a pilot very soon to look at that, and it includes nuclear medicine. We've done it across different. I can also tell you that we've had a massive flood of international candidates. I was furiously trying to find statistics in a different document that someone sent me. My belief is that they're primarily in general radiography. But if you remember back to that slide of the entire workforce, it's one ecosystem. So dealing with one shortage will help. It won't directly help today in nuclear medicine, but the pull for nuclear medicine people to go into CT, these things will slow down if we deal with the entire ecosystem. So I'm hopeful that that will happen as well. The growth has been, 50% growth in internationals over a few years. So taking certification, I'm not who knows how they'll integrate into the workforce yet, but we'll see with our pilot.
I think you prompted Alex to, you'd like to add to that?
Well, actually, I know that this is a big problem, but when I was rereading the question, and there is a part of the question that really struck me was like, how do we best work together, cross-sector, cross-functionally? And this webinar actually shows that we all have our numbers, we all have our informations, we all have our source of informations, and the thing is. And that was part of the recommendation that I put into the white paper, and we spoke about this during the annual conference of the CNM last year. So we need to have a coalition, which is why, I put the NCNMC on the table, being that coalition will allow us to be, seen, respected, represented. And sort of when we go talk to the people that make the decision, the people that have the control, the power to make things change, then we do have an entity that is recognized, which is why, when we say we best work together, we need that, when I'm looking at the atom, we have the nucleus at the center that, keeps all the others, elements rotating around. But this is the NCNMC. And then if we push that forward and we go knock at doors, and when I say knocking at doors, we want to bust those doors and be like, okay, this is the reality of it. This is happening. And Christopher mentioned it. MPs, government doesn't care when you say there's 1.5 in unemployment, but the reality is that 1.5, and if you take all those that retiring, going on the vacancy, leaves, mental leaves, physical leaves, sick leaves, take them all out. What's happening? Oh, too bad we are already into the hole and we're not able to get out of it. Too late, too fast. So we need to be proactive in a way and start building bridges to pass over. Laura, if you want to go for it.
Yeah, Alexandra, I just wanted to point out that the piece that is so relevant for Catherine and I is exactly what you just articulated, in the sense that when the department is too understaffed, they can't take students, and that there's just nobody there to do the teaching. And this is what we hear frequently, and it's a bit of a disconnect in the sense that, we're trying to educate learners so that they can get out there and help, but when the department is too understaffed, they can't support that. And so, yeah, it's a bit of a catch-22, I guess. It's just not really we can't go too far down that road without really having some infrastructure to get back the recruitment, the education pathways. So.
Yeah, that's true. That's true, Laura. Catherine, if you'd like to weigh in before we move on, I'm just looking at the time here, but I want to make sure that everybody gets a chance to weigh in.
I was just going to pick up on what Laura said. The other piece of it as well is that we want the learners to be in an environment that is conducive to learning, right? So when the staff are feeling those pressures, it's, and they're excellent people out there, but it does spill over, right? So it just perpetuates something that we're trying to correct.
Yeah, that's true. I think Alex also made a good point when he mentioned the word coalition. And I want to give a call out that the work he's been doing on his white paper, he involved so many different people from different walks of life cross-functionally. I think that was critical. I think even seeing the people coming here together today under CNIC and with the Canadian Association of Nuclear Medicine, our esteemed educational institutions, this is a critical area for us to work together on. So I guess any final thoughts as we look at developing this fragile but critical area for the future, for patients, for our ecosystem right now. How do we work together? What should we do first? And do we have any advice for people that want to enter this field? Catherine.
I'll start. So I think the call to action about trying to standardize how we are gathering data in order to be able to more accurately predict the needs is critical. And that collaboration across, across province boundaries, etc., definitely would help Laura and I as we're looking at what we should be doing as we're looking ahead, right? Advice for someone looking to enter the field. The field has never been more exciting. Yes, we're in a crisis right now, but it has never been a more exciting time to be entering the field. And there's going to be lots of opportunity. There continues to be lots of opportunity. And so my advice to folks who are either considering the profession or who are just about to actually, challenge their certification next month, which I wish them all success, is really continue to be that adaptable, adaptive innovator as this profession continues to evolve. Build on those core skill sets. They will take you far.
Thank you. Laura, could I ask for some feedback from you on final thoughts?
Yeah, I think that Catherine really addressed most of them there, but the next piece I'd say is for the audience today, spreading the word, letting young people know about the career, letting your families know what can happen for these careers. And then for those of you who have a voice within the ministries to say that, we are all part of the solution here. If we can work together, if we can be a little bit more strategic, we can actually solve for a lot of problems, not just problems associated with nuclear medicine.
Mm-hmm.
They can be problems associated with other fields. But nuclear medicine is a great place to start just based on the fact that it's very apparent the need is there and the growth is happening. So I just want to say thank you for everybody who's taken the time to join this conversation. And Alexandra for all the work that you've done over the last couple of years, and Chris for you sharing the information, because I think it's been fantastic.
Thank you so much, Laura. And over to you, Alex. Any final thoughts?
Well, I think that we could go for hours and hours and hours and hours on this. Let's be honest. The only thing I wanted to do actually is to thank people that are present, to thank all the speakers, to thank all the people from the industry, the association. I want to give a shout out to all the technologists. I know some of you are there. I'm not giving names, but I know some of you are there. I want to thank you guys for taking the time to fill out the survey, come speak to me, being part of this, because this white paper is not just the CNM white paper, it's the technologist white paper. So just wanted to, reiterate that without you, it wouldn't be possible. And I think that this field needs a joint effort because together we rise. So that like if we all push together, we can do stuff, we can move things, and I want to thank you for that. So that was my final thought about it.
Thank you very much, Alex. I think it's very appropriate that we have Chris with how he represents, give us his final thoughts to wrap things up.
It's hard to follow because I mean, I just want to echo what everybody just said. Important to thank, as Alex did, the technologists, certainly, who are working so hard at the moment with these shortages as they are. We know the work they do. We all know that nuclear medicine is a fantastic field, and it does amazing things for patients with its functional imaging. It's showing doctors things they just couldn't see otherwise. So thank you all so much. Thanks for attending if you did. And I mean, I think for me, the final thought is I'm eager to make a start. We've been trying to do this, some of us in isolation for a while. It's very exciting. I want to thank the CNM for really being the impetus to sort of put together this coalition. And I'm eager to start, and in whatever way. I mean, I'm hoping that we can just get on one of those curves and ride to a better place very soon with all these initiatives that we talked about today.
Thank you so much, Chris. I think you said it very well. I think we're all anxious to work together, and I've been so lucky to have colleagues like yourselves to have these discussions over the last few weeks. So, Evan, I'll hand it over to you for any wrap up.
Thank you so much, Kimberly. What a phenomenal discussion. I really want to take a moment to briefly thank our presenters and all those who joined us today. Just before we wrap up, I want to showcase some CNIC events that are coming up that we would love to have you at. The first one is on Monday, actually. It's the CNIC Awards, an opportunity for CNIC members to join us in celebrating some of the innovation that we've seen across the isotope sector in Canada in last year, 2025. Next up is also next week. On Tuesday, we will be at the CNA conference, Canadian Nuclear Association, showcasing the role that Canada's medical isotope supply chain plays in providing hope to patients across the country. Very glad to be joined by some of our member organizations for this panel discussion at CNA. And the inevitable one that we always have to talk about because it's our biggest event of the year is the Canadian Radiotheranostics Leader Summit. We're about 70% sold out at this point, so if you're planning to join us, be sure to get your tickets as soon as possible so you'll be able to join us in Toronto on May 25th and 26th. Academics, industry coming together in one room, about 500 folks will be joining us this year, so we're very excited for that. With that being said, thank you all for joining us for this great discussion today. Thanks to our wonderful panelists for joining us. And we look forward to continuing the discussion in the months and years to come. So thank you.